Hey guys, Dr. Brandon Crawford here. I'm the founder of the Austin Center for Developing Minds. We are located just north of Austin, Texas in Cedar Park. And what we do is we focus on developmental functional neurology. Hopefully you'll have a chance to catch my lecture because I'm going to be taking you through what that process looks like and why it's so important to focus on rehabbing the brain in the right way, at the right time, with the right frequency and oscillations and all this kind of stuff, right? So I'm very honored to be a part of this conference. This conference is very meaningful. I love all the people involved, and obviously the cause is fantastic. So thank you again, and I look forward to seeing you soon.
At Cook Children's, we know if we work together, we can keep each other healthy.
Wearing a mask keeps droplets from your nose and mouth trapped so you don't spread viruses to others.
Wear a mask when you're going to be around people outside of your immediate family.
Avoid large gatherings and wash your hands a lot.
These simple steps can limit the spread of viruses.
Let's all do our part to keep our community healthy.
Dear colleagues, my name is Andrey Boldyrev. I'm a medical doctor from Russia, from Moscow, and I've been working for the last 3 years for MNRI. And today I would like to present to you a lecture about progress in brain maps and neurotransmitters markers in individuals with diagnosed TBI and CP using the MNRI reflex neuromodulation program. So, what is the definition of traumatic brain injury, or TBI? Traumatic brain injury is a degenerative non-congenital insult to the brain from an external mechanical force, possibly leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions, with an associated diminished or altered state of consciousness. The definition of TBI has not been consistent with and tends to vary according to specialties and circumstances. Often the term brain injury is used synonymously with head injury, which may not be associated with neurologic deficits. The definition also has been problematic with variations in inclusion criteria. The Brain Injury Association of America reports that every year about 2.6 million people receive a brain injury resulting from trauma, tumor, stroke, or other illnesses. More than 5 million Americans suffering traumatic brain injury require assistance in performing daily activities. So this differences between TBI and ABI, that is, ABI is acronym for acquired brain injury. A person who sustains a traumatic brain injury is the result of an injury to the brain caused by external force. This can be suffered as the result of a motor vehicle accident, slip and fall, as well as injuries suffered from sport and recreational or other activities. An acquired brain injury is a brain injury after birth that is not caused by congenital defect, degenerative disease, or nor is hereditary in nature. It can be a traumatic brain injury, however, also includes injuries not caused by external force. Injuries such as tumors, stroke, or loss of oxygen to the brain and infections to the brain are examples of acquired brain injury. Here you can see the classification of traumatic brain injury, what we use in neurosurgery. It includes Glasgow Coma Scale from 1 to 15, post-traumatic amnesia, and loss of consciousness. It depends vary of time. We can put mild, moderate, or severe trauma. So, and the Glasgow Coma Scale is the most commonly used system for classifying TBI severity. And it includes eye movements, motor response, and verbal response. And the same system can be used for young children. And also we include patients with cerebral palsy, because cerebral palsy can be caused after the traumatic brain injury. And It's a syndrome of various disorders of the motor posture system resulting from permanent, non-progressive brain damage in an early stage of brain developing. And childhood cerebral palsy disorders result from damage to the developing brain during pregnancy, about 20%, the prenatal stage, about 60%, first year of life, 20%, and causes of cerebral palsy include abdominal injuries to the mother, chronic disease during pregnancy, malformations, fetal hypoxia, infections, the influence of ionizing radiation, drugs or toxins, including cigarette smoking and alcohol consumption, perinatal trauma, prematurity, brain injury, hypoxia after birth, severe neonatal jaundice, and neuroinfections. There are large numbers of individuals diagnosed with CP in the world, ranging from 1.5 to more than 4 per 1,000 live birth in the USA, and about 10,000 infants are diagnosed with CP each year. And the United Cerebral Palsy Association reports what more than 764,000 Americans have cerebral palsy. Each year, first schools have up to 1,500 students with CP. Most of the children, about 77% with cerebral palsy, have spastic or pathological muscle hypertension. They also can have at least one co-occurring condition. 35 to 50% of children with cerebral palsy have seizure disorders and some level of mental retardation, learning disabilities, vision, speech, and hearing problems. A few, about 7%, have co-occurring ASD. Over 40 to 45% of the children identified with cerebral palsy has affected motor coordination and are limited in their ability to crawl, walk independently, run, or play. Another study shows what 31% of children with cerebral palsy need to use special equipment such as walkers or wheelchairs. And depending on the area of the damage in the central nervous system and its symptoms, 4 main forms of the disease are distinguished according to the International Classification System, Gross Motor Function Classification System. It's spastic or pyramidal. It's about 70 to 80% of all cerebral palsy cases. Hypertonia or increased muscle tone muscles and their movements, and they're stiff and jerky. Second is dyskinetic. It's also called extrapyramidal, about 50% of all cerebral palsy cases. Lesion is in the basal ganglia as a result of bilirubin encephalopathy or an hypoxic ischemic brain injury. Third is ataxic, including cerebellum brainstem's injury, 5% of cerebral palsy, and causes poor motor coordination, balance and muscle tone regulation, tremors with possible speech and oral problems. And mixed, it includes spastic and non-spastic forms, which are the most numerous. In this presentation, we will talk about mosquito neurosensory motor reflex integration as a non-invasive method for evaluating and neuromodulate intervention for children with neurological and neurodevelopmental dysfunction, such as cerebral palsy, autistic spectrum disorder, also with TBI and ABI and others. And this presentation demonstrates the results of an MNRI intensive work with children with TBI and ABI, and they include 53 patients with this diagnosis. And we used 3 evaluation tools for comparative analysis of MNRI therapy and results for study group of children with TBI and ABI. First, we used brain mapping. It's quantitative EEG. And next, we used neurotransmitters. And the third, we use our MNRI assessments, MNRI reflex assessments. So, introduction to MNRI method describes in various words. You can see the links. And it addresses the neurosensory motor aspect of early sensory motor patterns and reflexes to support neurodevelopment and motor postural issues of children and adults with neurophysiological damages and neurodevelopmental issues. So to study the effect of MNRI treatment on the children with TBI and ABI, we have investigated the hypothesis what parameters of MNRI reflex assessment were correlate with the parameters of brain mapping and neurotransmitters, measured before and after the intensive reflex integration treatment. It was 8 days, 6 hours per day, and will show the enhancement of neurodevelopment in the individuals with TBI and ABI. We used pre and post evaluations with QEEG. So approximately 1 to 3 minutes of artifact-free eyes closed or eyes open EEG segments were selected after previously recording EEG with the DayMed TrustCon 32 and subjected to thorough QEEG analysis. And EEG equipment was combined with NeuroGuide QEEG applied by Neuroscience Incorporated software. EEG activity was recorded in a 10 to 20 electrode system using 16 leads. The EEG recording underwent an elimination of artifacts, after which the software produced QEEG maps of the EEG frequencies. The fast-forward transforms algorithm were used in the computer analysis, and spectral maps were compared in relative and absolute scale for the measured signals obtained before and after MNRI rehabilitation. And we analyzed the EEG spectrum from 0 to 30 Hertz, divided into 5 sub-ranges. So it's 0.5 to 4 Hertz, it's delta, 4 to 8, it's theta, 8 to 12 it's alpha, 12 to 20 is beta, and 20 to 30 is high beta. So, and out of 53 patients subjected to MNRI therapy, 42, it's about 79%, showed positive changes in previously identified QEEG abnormalities. And the most common abnormalities, what we can see on the brain mapping with our patients was frontal and temporal overexpression of delta and theta power. However, an elevated frontal and occipital beta or high beta power were also frequently recorded. And the degree of an improvement after the therapy varied from patient to patient, and only a small proportion of the patient showed no evidence of brain mapping improvements, about 21%, it was 11 individuals. 2 representative cases are presented which illustrate typical QEEG response to MNRI therapy. And case number 1, it represents 11-year-old patient diagnosed with CP, and brain maps showed marked overexpression of the frontal, delta, theta, and beta and high beta power. In addition, multiple abnormalities in amplitude, asymmetry, coherence, and phase lags were noted. As we know from our prior papers, an elevated frontal delta theta power as well as increased beta power are frequently seen in individuals with a brain dysfunction seen in ASD, ADHD, as well as other neurological condition. So this is the main patients here. And after completion of MNRI therapy, there was marked improvement of previously identified elevated beta and high beta power. In addition, some improvements in coherence or hypercoherence was also noted. This patient QEEG clinical response correlated well with the clinical response. So if you can see on the pictures here, you can see some delta theta power before the therapy, and you can see the changes right after, right? So you see the decreasing of delta power here and decreasing a little bit of theta power here. And we made this big analysis further, but this can show us the difference, these pictures. In case number 2, a patient, a 7-year-old diagnosed with TBI, and brain maps before MNRI therapy show evidence of a major increase in frontal delta, alpha, as well as frontal and central beta and high beta power. So almost similar to the previous patient. And after the MNRI therapy, QEEG maps showed a major improvement in frontal delta and alpha abnormalities, a marked correction of of frontal and central overexpression of beta and high beta power was recorded. And clinical response the same, correlated significantly with improvement in reflex function and sensory motor abilities level as the previous patient. And what we can make a QEEG conclusion here. Our current brain mapping study shows and allows us to conclude that rehabilitation using MNRI in individuals with CP, TBI, and other types of neurological dysfunction causes reorganization and at least partial normalization of spontaneous brain electrical activity. And this was most frequently observed in delta and theta frequency, as I showed you, as well as in beta and high beta overexpressed activity. This normalization of QEEG activity is likely correlated with the therapeutic effect of the MNRI program. This has been confirmed by positive clinical responses that were noted after MNRI therapy. And this serves as an indicator that the neurosensory development and overall function of these children are not static and can be improved, right? Independently of the neurological pathologies they have. Thus, the MNRI program offers an effective neuromodulator means of improving the overall functions of children with CP and brain damage, particularly and reflected in improvement of various functions and abilities in different areas: sensory motor integration, behavior and emotional regulation, communication, stress resilience, physical health, school skills, and achievement motivation. And this program potentially serves an exemplary tool for children with other neurological deficits and learning disabilities. Next study we made with neurotransmitters. And what are neurotransmitters? They are often referred to as the body chemical messengers, right? They are the molecules used by the nervous system to transmit messages between neurons or from neurons to muscles. Communication between two neurons happens in the synaptic cleft, like you can see on this slide. The small gap between the synapses of the neurons. Here, electrical signals that have traveled along the axon are briefly converted into chemical ones, right? Through the release of neurotransmitters, causing a specific response in receiving neurons. So there are three major forms of neurotransmitters functioning in a human organism, all of which communicate via signals targeting specific cells. There are acetylcholine neurotransmitter, biogenic amines, and amino acids. And we will describe 12 of them, what we measured before and after our therapy. And I just want to make a quickly brief review, overview of these analysis transmitters. Let's start from gamma-aminobutyric acid, or GABA. It's a measure inhibiting or calming neurotransmitter in a human organism. And the role of GABA is to inhibit or reduce the activity of the neurons of the nerve cells. And the calming effect is achieved by restricting neuroelectrical activity. The body relies on GABA to reduce anxiety, and the activity of GABA is increased during sleep, making GABA responsible for setting the circadian rhythm in humans. Other functions impacted by GABA, for example, include female hormonal cycles are affected by circadian rhythm. Next neurotransmitter is glutamate. It's an excitatory neurotransmitter what enhances signal transduction. It is tied to learning and memory. It is also one of the most common neurotransmitters. There is more glutamate in the brain than any other amino acid. Tissue extracted from the brain contains 5 to 15 millimole glutamate per kilogram. Glutamate is not only involved in cognitive and learning function. Being an amino acid, it has a role in metabolic functions and ammonia detoxification. Next one is norepinephrine. It assists the body to go into high alert and is responsible for increasing heart rate and blood pressure. Norepinephrine can activate not only pre- but postsynaptic adrenergic receptors. Norepinephrine is released in the brain as when the locus coeruleus is stimulated and the action potential occurs. It is also important for the long-term memory by influencing surges in specific neural circuits. When norepinephrine binds to a receptor and stimulates a nerve to respond, it works as a neurotransmitter. So it has different roles in our body, not only neurotransmitters, but also vasoconstrictors. Epinephrine is another fight-or-flight hormone released when the body is under extreme stress. It is closely related to norepinephrine, so it creating after norepinephrine. It's synthesized from norepinephrine in adrenal medulla. Norepinephrine and epinephrine are both hormones which act on beta and alpha receptors, and the difference is norepinephrine is primarily alpha receptors, what located on the vessel's wall. It causes vasoconstriction, whereas the epinephrine stimulates all three beta receptors as well as alpha receptors. So if you can see in medicine, epinephrine used with anaphylactic shock, and norepinephrine used as the vasoconstrictor and increasing blood pressure with the people in shock too. Next one is dopamine, is the third excitatory neurotransmitter. It's produced in two areas in the brain. The midbrain is the host of the substantia nigra, which is the part of the basal ganglia located in the midbrain, and it plays an important role in rewards and movements. High levels of neuromelanin in dopaminergic neurons make substantia nigra appears darker. That's why it's called nigra, means black, and the surrounding areas. One function of dopamine is movement, and the caudate hypothalamus create a striatum, which is a bundle of the dopamine neurons, what forms the nigrostriatal pathways, considered a facilitator of movement. The second function is that of the reward system, which originates in the ventral tegmental. So dopamine plays a big role in reward system. Serotonin, mostly produced in the enteric nervus of gastrointestinal tract and in the central nervous system in the nucleus raphe, has many important roles in overall health and well-being. It is a chemical product of nerve cells, serving as one of the modulators of voltage potential, regulating glutamate excitation. Serotonin is a metabolite of 5-HTP. Up to 90% of serotonin is produced in the gastrointestinal tract. Although it is also found in platelets and throughout the central nervous system. And serotonin is involved with smooth muscle contraction, regulating cyclic body process and nerve impulse transmission. Next one is taurine. Assists in the survival of the neurons following a synapse. This being called a trophic factor. It is a neuromodulator and regulates calcium. Taurine is a protectant against glutamate-induced excitotoxicity by limiting increase of intracellular calcium achieved by shifting the ratio of BCL2 and BAT ratio in favor of cell survival and reducing the endoplasmatic reticulum stress. And taurine plays an integral part in regulation of the amount of the sensory information received by the cortex. Taurine is partly responsible for helping the brain to turn off at night by activating gamma. Next one is histamine, has many physiological roles, has many receptors in our body. One of which is the ability to increase excitability of the central nervous system. Studies have demonstrated that histamine can be a regulator of all brain activity. The hypothalamus's ventral perioptic central center assists in turning off histaminergic tuberomammillary cells, which connect to the sleep-wake cycle, resulting in diurnal change in brain functions. Many functions of the hypothalamus are regulated by histamine, including vasopressin, what are physiologically regulated by histaminergic neurons. So we did analysis of those neurotransmitters plus some more. And the urinal analysis test panel for study included 12 neurotransmitters, applied 78 patients and control group, including 117 patients. The urine collection was performed on the first day of the conference and again at the last day of the conference. Urine collection was per manufacturer's specifications. The urinalysis test utilized was the number 9123 extended panel, and testing 12 neurotransmitters, as I said, particularly epinephrine, norepinephrine, dopamine, DOPAC, serotonin, 5-HIAA, glycine, taurine, GABA, glutamate, PIA, and histamine. And prior to the sample collection, the participants were ordered to fast for 8 hours and abstain from tobacco, avoid strenuous workouts, and not to take supplements or medications unless instructed otherwise by physician. The urine collected was the second urine of the day, collected 2 hours following wake up while still fasting. 2 milliliters tubes were collected to accommodate the volume needs. 1 vial contained a stabilizer as specified to maintain the integrity of the sample. The samples were kept refrigerated until proceed to the reference lab. And all the urine samples were proceeded by neuroscience lab and Mr. Brandon Peacock, who have no vested interest in MNRI, analyzed the results and compliance statistic. He was not given any details regarding the treatment or suspected outcomes. And all data presented in this report are the intellectual property of the neuroscience lab and Mr. Peacock. Let's see the results. So if you can see, this is a big table, and the conclusion on the down on the slide. So it says neurotransmitters analyzed in study group with the cerebral palsy children has shown different effects on different neurotransmitters, but most important here you can see epinephrine had minus 0.01, glycine had minus 0.3, means it decreases, and norepinephrine decreases by 0.2. And you can see the statistic of this norepinephrine neurotransmitters, sorry. And here you can see norepinephrine here. And norepinephrine decreases after the treatment, and it's the part of the sympathetic response. So a reduction of it is important when it comes to body physical response to stress, right? This data can be interpreted as the increase of stress resilience and better management of the HPA stress axis is some needed for motor control for CP child, right? And another thing here, you can see decreasing in glycine. I believe it's somewhere here. Histamine, GABA, glycines right here. Glycines plays a role with inflammatory response and immune response within the whole organism. And this could be significant when it comes to impact to the impact of glycine because of its function as the immunomodulator and being cytoprotective, right? So the data on the neurotransmitters also shows what the MNRI treatment resulted in impacting in the changes in the level of dopamine, norepinephrine, PEA, serotonin, and taurine, as I showed on previous slide. They all had between 0.2 to 0.3 impact, so it means it increasing a little bit, which is good, which could be categorized as a small effect according to Cohen's method. This reduction can show a reduction of inflammation in the nervous system. For instance, serotonin is known as one of the modulators for glutamate, and this could be significant because we know that high glutamate levels can lead to nerve damage or nerve death, which we presuppose as significant for the children with CP at their movement of CNS damage they went through in their disease etymology. And summary of this study. So the present findings in neurotransmitters changes suggest what the MNRI treatment positively impacts central nervous immune and endocrine system by regulations of the stress hormones and neurotransmitters. The results indicate that through treatment using reflex pattern, there is a reduction, there is effect in the excitability with the nervous system, and reduction in the inflammatory response, so it's norepinephrine and glycine. The results in the study group of CP children also demonstrated links with the other researchers, as I showed with QEEG and reflex level functionality, as I'll talk later. The next conclusion, what we can make from this study, the finding of neurotransmitters study suggests what MNRI treatment positively impact the central nervous system and immune system. The results indicate that through reflex integration treatment, there is a reduction in excitability within the nervous system, as well as reduction in inflammatory response, as we said 2 times before. This neurotransmitter regulation can have an effect on mood, behavior, focus, and cognitive function, which is true. By calming down the neurotransmitters and bring neuromodulation, this opens up the pathway for new learning, which you should agree. And the last, which we used for evaluation our method, it was MNRI assessments of 30 reflex patterns, what we use every time before and after the conference, every conference. So it includes 30 reflexes, and we done it twice prior the MNRI therapy and after, as I said. And evaluation provided based on the neurophysiological definition of the inborn reflex and its parameters such as sensory motor coordination, direction of the response, intensity, its muscle tone regulation, timing, dynamics of the response, and the symmetry. As you can see on the table, we have 20 points, which we divided on 5 groups. It's severe pathology, pathology, severe dysfunction, incorrect light dysfunction. I'm sorry, 10 groups. Marginal pathology and dysfunction, functional but low levels of development, functional but very low level of development, mature and integrated or corrected development. And every reflex pattern we divided on has 4 features, right? So 5 parameters, 4 features create 20 points, right? So it's tested accordingly the definition of the reflex. We test sensory motor coordination, right? So for example, this reflex is a hands grasp. So we check tactile stimulation on the base of the closed palms in a more intense proprioceptive way, deeper to activate palm flexors should trigger a stronger grasp response, right? Second feature, all fingers are closed and thumb is between index and middle finger. Third feature, as you can see here, elbows can be easily extended in front of the body for 180 degrees, and shoulder should be 90 degrees or more. So it should be differentiation between elbow and palm and shoulder is evident of a norm. And fourth is the arm palms are directed horizontally, right, to the body, to the ground. No abnormal abduction or adduction in the wrist joint, right? Every parameter has its own 4 describable features, I said. So, and results, as you can see on the slide, the MNRI assessment of reflex patterns of groups with the CP and CBI demonstrated. You can see all 30 reflexes, what we check before and after. It means in sagittal, horizontal, and dorsal axis of the body. So, and this data is pretty statistically significant, right? So here is better to view overall increasing in their scores after, before and after the therapy. So the red columns represents the pre-test and the green columns represent the post-test. As you can see, it's obviously increasing a lot after the conference, mostly by 2-3 points. And all this data we can conclude, well, analysis of the data shows several important facts and findings. First, the level of development of the reflex pattern in children with brain development deficit of the disorders were overall immature and dysfunctional. Most of them were between 4 to 6 points. Was 17 patterns. 11 patterns presented dysfunctional stage. It was 6 to 8 points, and 1 pattern was light dysfunctional. It was good. Score was 8 to 10 points, and 1 pattern was marginal between dysfunctional and functional. Level is like 10 to 12 points. Second, the result of post-assessment of the MNRI treatment in study group children with neurological deficit show what 22 of the reflex patterns, is about 73% out of 30 patients, have changed within 9 days of the MNRI. And this data demonstrates that dysfunctional or pathological reflexes are not static, as we said it before, and can be changed with specially oriented manual neuromodulation treatment versus traditional concepts approaching the abnormality as non-tangible state, right? And the data shows increases of 50% of reflex patterns to the next level from severe dysfunctional in 56% patterns to dysfunctional, 90% and 60% patterns to light dysfunctional level. And third, results of the post-assessment demonstrating a significant improvement in reflex patterns still show what they are on dysfunctional level, right? So we jumped from severe dysfunctional to dysfunctional, but it's still dysfunctional level. And our long-term clinic experience shows that we need 2 to 3 years of work in the program to provide the development of the reflex pattern at the functional levels. But this is average time. I think every time is individual. For somebody we need less time, for somebody we need more time. Conclusions after all these studies, we conclude with neurorehabilitation using MNRI method of reflex integration in 79.5% or 62 out of 78 children with cerebral palsy displayed a reorganization of spontaneous electrical activity in the brain, as we saw in QEEG study. This is observed in the alpha frequency range as well as in fast beta activity. Increased activity in these frequency bands during rehabilitation appears in the parietal and temporal locations. This may be connected with the positive and stable therapeutic effect of this method on the motor disorders originating in the central nervous system. Our observations are consistent with the findings of other authors who have noticed changes in EEG mapping in children with CP during experiments related to the motor system. And you can see authors here. The findings with the study of the effect of MNRI 12 neurotransmitters shows first, regulating effect, second, enhancement of stress regulation, taurin decrease and norepinephrine decrease, and anti-inflammatory effect improving the cytokinesis, as you remember, glycine decreases, an effect on the restoration of the nerve fibers, as serotonin is a modulator for glutamate, right? Hormonal changes supporting the muscle tone regulation and motor control support. The positive changes in reflex development of children with CP are seen in improvements of 66.7% or 26 of their reflex patterns out of 30, right? Within 8 days of the MNRI treatment program, showing new possibilities for their neurodevelopment. And all these 3 studies show significant positive results demonstrating the neuromodulating effect and possibilities of the MNRI reflex integration, what is providing a greater chances for children with CP and TBI to realize a more fulfilled and extended life, to be healthier and have better muscle tone regulation, postural and motor control, as well as include possibilities for enhancement of their cognitive abilities, right? Thank you very much. This is my references. Thank you.